Dear colleagues, thank you for the kind invitation. Dear Jorge Mejia, congratulations on pulling together such a wonderful meeting. It's a shame that I cannot be there in person, hopefully next year. So my assigned topic is how to detect delayed cerebral ischemia in the neuro ICU. And the only disclaimer I would have for this presentation would be that obviously I do provide some of my personal opinions and experiences, and also by our department, and therefore do not claim that this is by all means the ultimate reality or truth. However, I am going to also provide you some overview of the current literature in that sense to provide more objective data. So, as you all know, there are different determinants for neurological outcome in the setting of subarachnoid hemorrhage. And the most important one is early brain injury, meaning the initial disruption of brain tissue due to the hemorrhage following the aneurysm rupture. And the review, I apologize for not providing the reference here. This is the very nice review by Locke MacDonald in Nature Reviews Neurology, and I highly can recommend this as a very comprehensive review. Another determinant is, of course, aneurysm re-rupture, and we recently saw the data from the from the ULTRA trial in this sense on prevention of aneurysm re-rupture using tranexamic acid. Unfortunately, that trial was not negative regarding the experimental, was negative regarding the experimental intervention. And I think we need more research in this respect. But then, and I think this is something where we in the neuro ICU can actively prevent this, and this is why we're all convening here. Delayed cerebral ischemia, which is still a major contributor to poor neurological outcome, and of course, the aneurysm treatment per se, with a risk for poor outcome or death of up to 6%. And then, of course, other complications, meaning hydrocephalus, epilepsy, and cardiopulmonary complications, etc. So, just briefly regarding the pathogenesis of delayed cerebral ischemia, and this is a meta-analysis that we did with Locke MacDonald and Mervyn Fairgown almost, or actually a decade ago. And the background was that we wanted to understand the relation between the incidence of radiographic vasospasm, as seen in this picture, and in previous pharmaceutical trials to prevent radiographic vasospasm. And we saw that in those pharmaceutical clinical trials, there was a significant reduction of angiographic vasospasm. However, when we looked at the effect on poor clinical outcome, we did not see a significant effect on the reduction of poor clinical outcome in the experimental groups, which implied that radiographic vasospasm may not be the most robust or sole target in this sense. Additionally, we learned from the research of the worldwide groups that there are different pathomechanisms, including microvascular spasms, cortical spreading depolarizations, microthromboli, and so forth, that, if not prevented, cause cerebral infarction between days 3 and 15. And that again results in an acceptable neurological outcome without apparent motor deficits in about 33%. However, these patients do have in 10 to 20% neurocognitive deficits or anxiety issues. About 1/3 of the patient has a significant disability, and again, 1/3 of these patients unfortunately dies. So in the second phase of this project, we then looked at potential therapeutic targets for future trials. And here we looked at the endpoint cerebral infarction, meaning what was the effect of outcome when cerebral infarction was addressed as a therapeutic target, and if there was a significant reduction due to experimental treatments of cerebral infarction, there was also a significant effect of clinical outcome, which implied that we shouldn't look at angiographic vasospasm as a therapeutic target, but really at the reduction of cerebral infarction, mostly because this is the ultimate endpoint of the aforementioned other pro-ischemic pathomechanisms. So what data is there to predict DCI in patients that we have? And this is data from the SAHID collaboration and pooled data from 3 randomized controlled trials and about 750 patients. And I think this is a very good and robust classification beyond the classical Fisher scale, combining WFNS grade and modified Fisher scale and 3 categories. And the results were that if patients fall in the vasograde red category, they have a 3 times higher odds for developing DCI. And I think this is a very easy applicable tool, excuse me, to identify patients irrespective of other things who are at increased risk for DCI. So there are different means to diagnose DCI in the ICU, and I will focus predominantly on the red indicated modalities. I've spoken already about the role of DSA for assessment of macrovascular spasm, and we do know that about 70% of patients have angiographic vasospasm on any given day in this first 2 weeks of subarachnoid hemorrhage ictus. However, that translates only to about 30% of patients having clinical features for DCI. So what is the definition of DCI? And I think most of you know this paper by Mervyn Fairgown and colleagues, which was a consensus statement. And it's defined as the occurrence of focal neurological impairment or a decrease of at least 2 points on the GCS, which should last at least 1 hour and is not apparent immediately after aneurysm repair and after exclusion of other causes. So it's a diagnosis per exclusionem, meaning that this is a pure clinical diagnosis according to this definition. However, and this is the topic of the talk, in the neuro ICU, we do not only have neurologically accessible patients, and in our experience, we have about 30 to 40% of patients which have to be sedated or are comatose initially. And in these patients, we need other modalities. And of course, TCD, and this is just one meta-analysis published a couple of years ago, has been around the block for a while. And we know that the sensitivity is actually quite acceptable with a lower specificity. And I guess it is fair to say that TCD has an additional value, and it's best if the same individual does TCD recordings in given patients over, for instance, a week. But if the raters change every day, then the sensitivity goes down, and we do not do it anymore. But I think it provides helpful additional data, if you will. So what about perfusion CT imaging? And this is a meta-analysis from Mervyn Fairgown's group. And first, for prediction of DCI, and the limitation of these underlying studies was that early perfusion imaging here was defined as perfusion imaging within 24 to 72 hours after SAH ictus. And it was compared here. So patients who developed DCI or didn't, and these are the differences in means for the 4 parameters that we know. we usually use the mean transit time, and you can appreciate in all of these meta-analysis for the given parameters that there's really no difference between patients who develop DCI or who do not develop DCI according to the initial CT perfusion scan. What about the confirmation of DCI in the following 2 weeks? And here again, patients who developed DCI versus who didn't develop DCI. And you could see a trend here for CBF, excuse me, which was driven by 2 studies and also mean transit time. And I think this also underlines our current practice in this sense, but again, no overall striking signal. So what about our own experience? And this is a paper that we published, and this was always with Daniel Hengi, my long-term colleague in Düsseldorf, excuse me, which was early perfusion CT imaging defined as within 6 hours after SAH ictus, and subsequent CT perfusion imaging, excuse me. And here we saw that if we build a risk model, and I will come to that in a minute, the association between the initial risk group allocation with subsequent cerebral infarction and clinical outcome at discharge or at 6 weeks was quite strong, especially much stronger than our established clinical or radiological classification scales. And what do I mean by risk group allocation? Well, we defined 3 groups, and we used another parameter in addition to CT perfusion imaging, which was clot volume in 3 different categories, and dichotomized, if you will, at 50 cc, and our baseline early MTT values at 4.2 seconds. And you can appreciate that if the patients were in the high risk group, there was a significant increased risk for poor clinical outcome at 6 weeks, defined here, compared to the low risk group. And I think that's a helpful tool, and it's obviously not the ultimate truth, but it's another tool to identify patients at risk who are comatose, for instance. So how do we do it at our center? Well, all patients in Mannheim are monitored roughly 10 days in the neuro ICU, rarely on the intermediate care. And what we do is within 24 hours, we do really a CT perfusion, and CTA scan as baseline. Then following aneurysm repair, we do another CT and CTP. There's a daily neuro exam every 2 to 4 hours. Additionally, this is after, and I will explain that the difference between these 2 groups in a minute. But initially we did it daily, and now we established the SOP where we do it every 2 to 4 hours. We do 1 CTP imaging on day 3 to 4. However, if a patient is well neurologically accessible and, for instance, young, we then also divert from this. And then we do a digital subtraction angiography in those patients who are clipped for their aneurysms for quality reasons, to assure that the aneurysm is completely secured. In coiled patients, we would do a clinical exam or a CT perfusion if not possible, and another CT perfusion at the end of the vasospasm period, if you will, between days 9 and 11. And so this is our standardized scheme for monitoring, but also for the treatment. So what do I mean by that? Excuse me. So before we implemented this SOP that I will show here, there was simply a neuro assessment daily. The patients were on a multidisciplinary, not specialized ICU, and they simply got a DSA when there was a neurological worsening, and if there were vasospasms, they got a nimodipine catheter, and it was lasted for 72 hours. So this was until 2016, and when we came to Mannheim, we established this algorithm where we really screened our patients according to the scheme that I showed you. And if the main transit time was worse or prolonged than 1.5 times compared to the baseline, we go to the angio suite. If we see severe vasospasm, we induce hypertension on a risk-based model, and only if the perfusion deficits persisted after the scan 24 hours later, then we go in with the intra-arterial nimodipine treatment for vasodilation. And I guess this is a tailored approach and risk-based approach. And here you can see a little bit the patient cohort. So about 140 patients in the pre-SOP phase within 2 years until 2014, and then about 160 patients between 2016 and 2018. And the only real difference was that the Fisher scores were much higher in the more recent phase. So they were at higher risk for DCI, and more patients were treated with surgical clipping compared to the previous cohort. And regarding radiological outcome, you can appreciate here for the overall cohort a real significant reduction in cerebral infarction incidence in the new era, so using the SOP, and especially also in DCI related infarctions, there was even a more pronounced effect. And also regarding clinical outcome at discharge and at 3 months. So at discharge overall, there was a trend, but at 3 months, this was a significant trend. And if you look at DCI patients, only the implementation of a perfusion-based treatment algorithm resulted in significant improvement of neurological outcome. So to conclude, DCI is a clinical and not radiological term, and it's a multifactorial phenomenon. Macrovascular spasm is one contributor amongst others. In the ICU, TCD has a high specificity but moderate sensitivity. Perfusion CT data in the previous meta-analysis may be too heterogeneous to provide robust also guidance, but however, in our personal opinion, we think that it is beneficial in patients that are comatose and therefore not neurologically accessible. And other modalities, which I didn't talk about today for time reasons, such as EEG and NIRS monitoring, may also provide additional useful information. But further, and I apologize that this is missing here, but of course, more robust studies are required in this sense. I appreciate the invitation to this wonderful meeting, and you're welcome to email me if you have specific questions. Thank you very much.